So the question is, why is that? And what is blink? And is blink important, or is it useful, or do we just not care? Well, I think we care. Why should we care about first impression? Because it's a useful human thing. And lots of study, lots of investigation looks at blink impression as something which can help people make better decisions if they understand how it works, right? So this guy, Malcolm Gladwell, publicized the idea. I think you can use first impression and blink impression interchangeably, that those words mean the same. And the question is, well, how does it work in colon polyps? Well, in colon polyps, blink potentially is related to different things, and we started to think about it. So potentially, if we broke the blink impression down into these 6 things, we could make it a bit more tangible. So right now, blink impression is like, yeah, how do you do that? Well, it's just my feeling. But actually, maybe if you apply this approach to it, you can be a bit more scientific about it. And it turns out that that is the case. So in like 250 people who answered a questionnaire about 20 polyps, this is what you found, that if people identified one blink feature, that polyp histopathologically did not contain cancer. Whereas if they identified 2 or more than 2, that it did, and that was significant. So maybe this is a way in the future to look into blink impression. It's not there yet, but certainly the message, if you're not an experienced person, you've not been doing polypectomy a lot, and you don't understand endoscopic imaging, is blink impression is useful, but make sure you look closer. So to summarize the risk of cancer in polyps which are not obviously having cancer on the surface, this to your question, they are more likely if they are big, if they're in the rectum, if they're non-granular, the smooth or shiny type, and if they have a big nodule. So I don't know what that one that you were describing, was it any of those?
It was in the rectum, it was a large polyp, and yeah, I think non-granular.
So the highest risk on this. So the decision is based upon your patient, right? Because we're doctors, we're not machines. Patients have views, we have views, MDTs have views. And so it depends. If you have a 75-year-old man with extreme cardiac decompensation who's maybe going to live another year, then that 20% maybe doesn't mean anything, and you can do piecemeal EMR on that. Whereas if it's a 40-year-old guy who's otherwise fit and healthy with a high-risk polyp, then maybe the risk changes.